Hello, my name is Nicole Quee, and I'm the Section Chief for Transfusion and Apheresis Services at the Hospital of the University of Pennsylvania. I'm delighted to give this talk entitled COVID in the Rearview Mirror, Pandemic and Disaster Preparedness on behalf of the Society of Black Pathology. I'd also like to thank the ASCP for inviting me to share our experiences with you. Sadly, I have no financial relationships to disclose. Now, my objectives for this talk are one, to define disaster and disaster preparedness. Then we'll review lessons learned from the COVID-19 pandemic about disaster preparedness from a transfusion medicine perspective. Again, transfusion medicine is all that I do. However, I do believe that the lessons that we've learned during the pandemic are certainly relatable to other aspects of the lab. And then we'll use some real life case studies to discuss considerations when dealing with disasters or emergencies. All right, let's start off with some definitions. Now, the WHO defines disaster as any occurrence that can cause damage, ecological disruption, loss of human life, deterioration of health and health services on a scale sufficient to call for extraordinary response from outside the affected community or area. And disaster management is a continuous process of reducing the impact of disasters. I really want to make sure I put the emphasis on continuous, because this is not a one-time thing where you come up with a plan and you forget about it. You want to test your plan, and I'll talk more about that in a little bit. Now, the goal of disaster management as it relates to healthcare is the optimization of patient care, ensuring visitor, patient, and staff safety, as well as maintenance of operational efficiency until the event is resolved, and guidance on post-event recovery. Now, there are different types of disasters. There are internal disasters. These are events that occur within the walls of the hospital itself, such as an active shooter, a power outage, a radiation exposure, flooding in the lab. Then there are external disasters, and these occur at locations separate from the hospital, such as transportation incidents or industrial accidents. Now, there's also acute and ongoing. So acute disasters have events that start at a time of onset. So you can say, this is exactly when it started. And they have a typical flow. So normally, numerous patients will present to the hospital, which overwhelms the surge capacity or the number of patients the facility can care for presenting at a single time. And then there are ongoing disasters. And these are evolving disasters such as infectious pandemics, COVID-19, that have a gradual progression to critical populations, but volumes and resource strain remain for extended periods, and we've certainly seen that. All right, so then you have human disasters, and those can be broken down into environmental, so things like the greenhouse effect, or technological. These are hazardous substances, radiologic accidents, terrorism, riots, bombings, things like that. These are not at all an exclusive list. There are certainly other types of human disasters, but these are the most common. And then you have natural disasters, and you can see this list is even longer. So there's biological disasters such as the epidemic, insect infestation, geophysical, which would be earthquakes, volcanoes, meteorological, hurricanes, tornadoes, climates, so extreme temperatures, drought. And then I had to put this on here, extraterrestrial. If anybody's a movie fan, you've seen things like Deep Impact or Armageddon, where the risk is of a meteor or an asteroid crashing on Earth. And that's what obviously killed the dinosaurs. So hopefully that is not an issue for us, but it is something that could happen. All right, so disaster emergency planning. CMS requires the development and maintenance of an emergency preparedness plan for healthcare facilities in anticipation of any type of disaster and for facilitating coordination with local, regional, state, and federal emergency preparedness teams. So this is a requirement. So when we talk about disaster preparedness, we'll talk about the importance of it, but it's also something that you have to do. Accreditation organizations such as the ABB, CAP, and FACT also have standards regarding emergency preparedness and operations during disasters. All right, so before you start planning, the things that you need to do are risk assessment. So in a risk assessment, you're going to identify high priority and vulnerability areas. And this is where you're going to direct your mitigation efforts to those high priority and vulnerability areas. Then you have identification of possible disasters that challenge the area, including both internal and external disasters. So when we're talking about challenge the area, these natural disasters would be location specific. For example, if you're on the West Coast, earthquakes are a serious consideration. In the Midwest, you may be concerned about tornadoes. In Florida and other areas of the South, hurricanes are a major concern. In the Northeast, we've had crippling ice and snowstorms. So really, you need to customize your disaster plan for what would actually happen where you live. And then resource inventory. So what do you have on hand and what can you get in an emergency? What are the capabilities of your facility? So your disaster plan should indicate both natural disasters that are known to affect the area, as well as possible mass casualty events, and understanding of the facility capabilities in regards to the patient population, and identify vulnerabilities such as specialty coverage or transportation, and focus on priorities like limiting the loss of life. So there are 4 phases of disaster management. The first is mitigation. Now, mitigation are actions that are performed before the disaster occurs. It includes proactive steps to limit vulnerability and address previously identified risks to support the response to disaster, which is why the risk assessment is really the first step of that disaster planning. Now, mitigation strategies are generally disaster specific. You're not going to be able to account for every single possible disaster. So you're going to speak more in broad terms and generalities. Mitigation measures can be as simple as mounting appliances to a wall in an earthquake-prone area, including emergency power or natural gas shutoffs, or as broad scale as creating floodways or canals in flood-prone areas. In general, mitigation efforts are investments in facilities or regions to limit response from disasters as identified by that risk assessment. Then you have preparedness. So preparedness are those measures taken to prepare for a disaster. And again, so we're preparing for something that we cannot prevent. In the response phase, you're going to focus on executing the disaster plan. Emergency response encompasses both the facility level as well as regional and national level planning. The initial primary concern is fulfilling the basic humanitarian needs of the population affected, as well as limiting loss of life. Types of medical care will ultimately depend on the disaster type. A substantial task within the response phase is coordinating efforts between a facility and regional response, particularly when the demand has exceeded the facility's capacity. And then we have our salvage and recovery phase. Now, this occurs after determination of the initial response. And the immediate threat to human life is under control. Efforts begin to return the facility or area to normal operational function as quickly as possible. The most intense circumstances would include ongoing wartime environments or prolonged epidemics, which inhibit salvage and recovery for years, as we've seen with the pandemic. All right, so this is the disaster cycle. So we'll start with mitigation and prevention. Again, so here we're going to attempt to reduce the negative consequences of a disaster or decrease the probability of it happening. This is where that prevention comes in. Preparation, where this is planning, training, and educating for events that cannot be prevented. Not all disasters can be. And then you have the disaster, right? So once the disaster occurs, you go into your response mode, which will decrease morbidity and mortality and property damage after a disaster has happened. And then you move into your recovery phase. And those are actions that are taken to return to normal after the disaster. How do you return to normal? I think, with COVID-19, what we've seen is a new normal, right? So we're not going back to exactly the way things were. The lessons that are learned during this recovery period are used to mitigate the impact of future disasters, and the cycle continues. All right, components of the disaster plan. So who performs the notification is determined whether or not the disaster is internal or external. So in an internal disaster, say a machine breaks down, loss of power, that notification may come from a technologist, a manager or supervisor, whoever discovers it first. External disasters are usually communicated from hospital leadership or somebody outside of the lab. They usually involve creation of a command center. Because the laboratory touches on every specialty, it's vitally important that a pathology representative is a part of that command center. They need to be at the table for discussions about the creation and implementation of the disaster plan. Next comes the assessment. So how bad is this disaster? The lab division director and/or administrative director, lab managers of the affected area, they'll need to assess the situation and recommend action. So is it minor? Minor damage and minimal disruption of the service is expected. So then work may continue in the area once repairs or cleanup has been completed. So in this case, the minor disaster or minor emergency, no relocation of equipment or personnel is necessary. Then we have moderate. So moderate damage and interruption of service is expected. Relocation within the department of essential equipment, instrumentation, and personnel may be required to continue service. The specific site and plan for continuation of service should be developed and communicated at that time. And then we have significant damage and loss of essential equipment or power causing major disruption of service. So a decision needs to be made as to whether a lab section can perform that essential functions that are normally provided by the damaged section. If no section can perform these functions, then plans for referral of work to one of the department's current reference or health system labs will be initiated, right? So if your lab can't do the work that it's supposed to do, who is going to perform that? And that's where the planning comes in, because that needs to be established ahead of time. All right, implementation. So staffing. During a disaster, the lab's primary goal is to conduct operations in a manner that would provide primary support for the hospital's inpatient services needs, and if feasible, to provide support for outpatient services. So the concentration obviously is going to be in those sicker patients who are admitted to the hospital, and if possible, to provide outpatient support. Depending on the extent and severity of the staffing shortage, curtailment or discontinuation of some lab services may be required. And then evacuation. So for, these are generally for internal disasters, fires, and things like that. Primary and secondary egress need to be established. Again, this needs to be established ahead of time. Establish a gathering point. So once people leave the lab, where do they gather after that? And then there needs to be a designated person in charge who performs roll call to ensure that everyone has made it out of the lab safely. And then recovery. And again, recovery is going to be determined by how bad the disaster is. All right, moving on to the COVID-19 pandemic. So just some things that you probably already know, but the pandemic, 760 million people were infected worldwide and almost 7 million deaths. There's an estimated cost of $16 trillion in the US alone. And this is from lost GDP, premature death, long-term health impairment, and then mental health impairment from the pandemic. Effects on healthcare. So acute admissions during the waves of infection. And we've certainly seen that where census reaches a critical mass, and then it goes down and then it comes back, depending on again, waves of infection. A ballooning intensive care unit and hospital censuses. Shortages of mechanical ventilators and critical medications. and decreases in the ability to manufacture and transport products that are vital to healthcare from worldwide shutdowns. So what are the effects of the pandemic on the laboratory? Well, in anatomic pathology, elective surgeries were canceled, so there were significant decreases in volume. However, on the autopsy service, there was the development of protocols to deal with confirmed COVID cases. And I should have said that I'm talking specifically about the hospital at the University of Pennsylvania. I'm sure similar effects were seen in laboratories around the country, but I'm talking about particularly our experience. All right. In clinical pathology, we saw a ramp up in services. So microbiology and the molecular pathology lab worked to rapidly develop and expand COVID testing. And there was redeployment and training of staff to allow this to occur. Once reliable COVID testing was in place, the lab became responsible not only for patient testing, but also employee testing through occupational medicine and testing of the University of Pennsylvania students and faculty as part of efforts to return to in-person learning. So Project Quaker was a large-scale COVID-19 screening program. This massive testing infrastructure was created in a matter of months, thanks to partnerships and collaborations across Penn Medicine and across the university. This allowed Penn, meaning the lab, to conduct 40,000 saliva-based COVID-19 tests every week, including twice-weekly tests for undergraduate students and those living on campus, and weekly tests for graduate students, faculty, and staff who also were on campus. So a little bit about the transfusion medicine service before I talk about how COVID affected us. So the transfusion medicine division is comprised of the blood bank. We do about 65,000 transfusions a year, so we're a pretty busy service. The apheresis unit, about 4,000 apheresis procedures a year, including red cell exchange, plasmapheresis, cellular collections, and lipoprotein apheresis. About 350 stem cell transplants, 150 commercial CAR T, and then numerous cell therapy studies. So we stay busy. So what key areas did we see in the pandemic? I'll go over each of these in turn, but communication and engagement, critical supply shortages, and then staffing shortages. All right, so emergency communications plan. It is important to communicate and develop plans with healthcare facility leadership and essential service lines so that realistic expectations about what is feasible can be established until normal operations resume. That is key. Setting realistic expectations of what the lab can do. Engaging stakeholders early. And stakeholders would be shipping and receiving, pharmacy, other laboratories, accounting. Do we need to send things out? Anything that's going to require additional billing, accounting needs to be aware of. And then personnel management, internal communication. So we have external communications to hospital leadership, but then internal communications within the lab itself. So daily huddles were really an important check-in to communicate constant changes in this kind of ever-evolving situation in real time. So we did have daily huddles during the pandemic, and that's one of the lessons that we learned when we continue to do daily huddles as well. All right, so blood shortages. There was a critical nationwide blood shortage in January. And I'll talk a little bit more about why that occurred in the next slide, but I'll first talk about some of the things that we did differently. So non-operating room orders, we triaged all orders of type B and O blood. In addition, all orders of greater than 1 unit for other blood types were reduced and triaged. And when we say triaged, we mean that the ordering provider received a phone call and said, okay, again, we're in a critical blood shortage. Can you hold off or can you cancel this order? For operating room orders, the blood bank triaged all Preoperative type B and O blood orders. Other blood types were automatically restricted to 2 units, with the exception of cardiac, vascular, and solid organ transplant procedures. Only 2 units were prepared and cross-matched for the patient. If there was a need for greater than 2 units prior to the start of surgery, the ordering provider was instructed to call the blood bank, and there was a discussion between, we have residents on our service, thankfully, but they spoke with the physician, either the resident or the attending, about the need for additional units. All intraoperative orders for greater than 2 units were triaged, and the anesthesia provider was contacted by the blood bank to document the need for greater than 2 units. All right. So, why did this blood shortage occur? Because it didn't occur in 2020, right, during kind of the height of the pandemic. It occurred 2 years later. So, how did we get here? One, ongoing infections. So donors were sick. So there was a decrease in the number of donors. And then we had community blood drives that usually took place in offices. Well, everybody was working from home. So offices were shut down. So those community blood drives were canceled. Blood drives in schools were canceled. And so just the ability to collect blood in as normal was not there. But again, this critical nationwide blood shortage happened in January. One of the things is holidays. Donations always go down during the holidays. And so we expect to see that. But combined with bad weather, increasing snowstorms that prevented donors from getting to donation centers, it just, was this whole Swiss cheese model of bad, that led us to this critical shortage. Staffing limitations. So even if donors could get in, this is at the time of the Great Resignation, and the Red Cross, who is our blood supplier at Penn, was not immune to those effects either. And so at one point, the majority of distribution centers had a 1-day supply or less of blood. And the Red Cross had said that this is the lowest blood supply they'd seen in over a decade. All right, so what are other things that we did to mitigate this, the effects of this blood shortage? One, we made changes to the transfusion order set. So we put in a banner, and we use Epic for our EHR. A banner went up that said, due to a critical nationwide blood shortage, providers should only order a single unit of blood or platelets at a time, unless clinically indicated. And again, they would get a call from a physician if they ordered more. The platelets and packed red cell orders defaulted to 1 unit. That doesn't mean they could only order 1 unit, it just defaulted to 1 unit, and it could be manually changed if clinically indicated. We also adjusted our massive transfusion protocol to decrease the number of red cells that were used in the first round. And this change has actually become permanent because we saw no ill effects of using less units, and we actually ended up with less wastage. And so again, part of that recovery phase is learning from that experience and using those to go into your next mitigations. And so, like I said, this change has become permanent. All right, changes to practice. So intraoperative cell salvage is a method of harvesting red cells shed during surgery, processing and preparing them for safe return to the patient's own circulation as an autologous red cell transfusion, either during or immediately after the surgery. So prior to this critical shortage, intraoperative salvage was used at Penn, but not universally. So with the shortage, surgeons who had previously not used the cell saver were strongly encouraged to use it if appropriate. And this resulted in less units used by the operating rooms, which was great. And then moving on to red cell exchange. So at Penn, the #1 user of red cells is the cancer center. #2 is the apheresis unit. So, we store the blood and we use the blood. We have about 75 adult patients with sickle cell disease who get maintenance red cell exchanges about every 2 to 4 weeks. During these exchanges, we use anywhere from 4 to 12 units. So again, you can imagine the number of units that we go through in a month. During the height of the pandemic, or I should say during the height of the blood shortage, because again, these two were separated by almost a year, we reviewed the blood orders for every single one of our sickle cell patients. In cases where it was deemed safe, we switched them to simple transfusions of 2 units. We don't like to make changes to patients' treatment plans without discussing with them. So I actually met with the patients when they came in for treatment and discussed the plan with them, letting them know why we were doing what we were doing and that it would only be temporary. And by temporary, we mean 1 or 2 treatments, then we would go back to exchanges. If the patients were uncomfortable with this plan of doing simple transfusions, then we did perform a red cell exchange, but we did it with a reduced number of units. There were no adverse events related to these changes, and we were able to resume normal operations within about 4 weeks. With some of our patients, again, we saw that they didn't have any adverse outcomes from using a reduced number of units in their exchanges, and so we were able to make those permanent changes. Another thing that we did is an internal blood drive. So Penn does not have a blood donor center. As I stated previously, we purchase most of our units from the Red Cross, and we have a secondary provider as well. However, Penn Medicine is comprised not only of the 3 downtown Philadelphia hospitals, but also additional hospitals in Princeton, New Jersey, and Lancaster and Chester counties in Pennsylvania. Lancaster General Hospital, again, is in Lancaster County. It has a very active blood donation center. For those who are unfamiliar with Lancaster County, it's home to a large and vibrant Amish community. So as blood products grew scarce, the Lancaster General Health Blood Donation Center partnered with the Penn Transfusion Center in Philadelphia to hold 2 all-day blood drives at Penn, so in the city. The LG Health Blood Donor Center and the team at HUP used equipment, materials, and staff from both locations. So the staff at Lancaster General graciously came to the city. It's about an hour drive, but worked together with actually the nurses and staff from apheresis to collect as many units as possible per hour. So some of the staff from Lancaster General arrived the night before in order to allow them to set up, prepare for the blood drive. And thanks to their commitment and passion and resilience, the team collected a total of 153 units from 180 individuals. And so all these products went back to Lancaster General Blood Bank for final processing, and then they came back to HUP for use. So it was a really fantastic collaboration that allowed us to get, as I said, 100, over 150 units that we would not have had. All right, moving on to critical supply shortages. Why did this happen? So shifts in demand, labor shortages, and then shipping issues. And what kind of critical supply shortages am I talking about? Apheresis procedure kits. Again, I said we do, with 4,000 apheresis procedures a year. And so we were running out of kits, blood collection tubes, 5% albumin, which we use for replacement, and then certain medications that we also use during the procedure, and then PPE, which was a problem for, not just us, obviously throughout the hospital and throughout hospitals in the country. Part of our disaster plan says that each lab section must keep at least 2 weeks of inventory for performance of critical assays, and that our current contracts with primary vendors do provide emergency shipment of supplies and reagents for critical assays when needed. Well, that's fantastic on paper, but we were at the point where our vendors could not provide emergency shipment of supplies. And so where do you go from there? All right, so what were our mitigation strategies? 1, evaluate and adjust our inventory par level. So we did increase our par level for certain reagents and supplies in anticipation of shortages, knowing that we were cognizant of expiration dates and frequency of use. Our supplies generally don't expire. We use them, we're very busy. And so we did increase our PAR levels to make sure that we're able to continue operations. Another thing that you can do is establish a network of sharing and backup. For apheresis centers, we are not, but for ones that are part of a healthcare system and perform a large number of procedures, supplies and critical reagents may be shared among the member hospitals according to the PAR levels or anticipated needs at predetermined frequencies. So if you're a part of a health system where there's multiple centers doing apheresis, it may be a good idea to share that inventory. And that leads us to the establishment of a central repository. So you can establish inventory control and distribution using a central repository. For independent apheresis centers, partnerships may be formed with other centers to share critical supplies and reagents during emergency situations. So having agreements in place prior to a disaster event would help to mitigate disruption of operations when disasters do occur. So thankfully, right next door to the Hospital University of Pennsylvania is the Children's Hospital of Philadelphia. And so we have shared supplies in the past, including apheresis kits, because they use the same kits that we do. And, in an emergency, again, they are literally right next door. We can walk back and forth, and it makes it a little bit easier to deal with these supply disruptions. So you can select or obtain alternative qualified vendors and suppliers, and find and validate suitable substitutes. So the validation part is incredibly important. Validation plans, as you all know, must include the background, purpose, procedural steps, expected results, and acceptance criteria at a minimum. The performance of the existing reagents and supplies and the new reagent supply should be compared in the same study if possible. And all results should be documented appropriately and assessed by a qualified individual, such as the medical director. And patient outcomes should also be monitored. And then review process deviation and relevant regulations. Again, you're going to want to make sure that any deviations from SOP are documented as appropriate. Other mitigation strategies. So specifically in apheresis, we could modify procedure parameters and replacement fluids. So for example, if we're running low on kits, we can decrease the number of procedures we would need to do for a specific patient by increasing the plasma volume that we are processing during each procedure. Another option is to consider alternative options for medications. Again, communication with key stakeholders regarding possible impacts of shortages and mitigation strategies. Triage procedures and transfer. So a hospital committee should be formed, and charged with deciding which indications would be prioritized to undergo apheresis procedures to ensure quality and avoid bias. Certain apheresis procedures may have to be postponed or discontinued or only offered in an emergent or life-threatening indication. Patients for whom procedures cannot be performed may have to be referred out or transferred to other centers that do have those critical reagents needed to perform the apheresis procedure. And then the establishment and implementation of a utilization review committee. So if you're going through all of these things where you've got to triage the procedures that we're doing or looking at alternative options, you really should be reviewing those results. So the establishment of a utilization review committee would be an important part of looking at the quality of what you're doing. All right, so staffing shortages. Again, triaging procedures. So one of the things that we use in apheresis are the American Society for Apheresis guidelines to determine if something is a category 1, a category 2, goes all the way to category 4. Category 1 and 2 are the categories where apheresis has been shown to be effective. It is either first or second line therapy. And so I know some institutions decided that they were only going to perform apheresis for indications that were a category 1 or category 2. And so having a strict review and approval process for procedures outside of routine clinic hours, if you're already short-staffed and then asking nurses or to other technical staff to stay late or come in the middle of the night for procedures, you're going to burn them out. And so you have to really think about what constitutes an actual emergency. One of the things that we did at Penn is that we canceled or decreased the frequency of non-urgent or elective apheresis procedures. So for example, all non-COVID research-related procedures were canceled. We do a lot of research at Penn. And so we kept doing, again, COVID-related research, but most other research procedures were canceled. Another thing that you can do in apheresis is to evaluate the possibility of decreasing the cellular collection goal, as well as the number of procedures required to achieve the goal by augmentation of mobilization. So prior to the pandemic, about 50% of our patients received plerixafor for mobilization, and it was based on the transplanter's preference and insurance coverage. During the pandemic, and now, again, this is something that has been maintained, almost 100% of our patients are getting plerixafor, which has resulted in fewer collections per patient to achieve their stem cell goal. Another thing that we can do is consider alternative treatments if available, such as IVIG instead of doing plasma exchange, or as I mentioned before, with our sickle cell patients, doing a simple transfusion versus a red cell exchange. All right, other ways that you can mitigate staffing shortages, you can modify shift or coverage structure. So one of the things that we did was we went to platooning. So platooning is when you have teams so that if everybody isn't there every day, so that if there is a COVID exposure, everyone wasn't put at risk. And so we had an A team and a B team, and we switched every day. So A, B, A, B. We also changed our shifts. And so instead of doing, 8-hour shifts, some shifts went to 10 hours or even 12 hours. Again, to lessen the number of staff that we needed and physician coverage that we needed for a particular day. Cross-training of staff where appropriate. So for example, dialysis nurses could be cross-trained to perform apheresis. We didn't do that, but I know other places that did. Because apheresis is so incredibly specialized, we wanted to limit apheresis staff's function to apheresis specific tasks by providing support for the non-apheresis specific functions. And again, this isn't just apheresis. There are other areas of the lab where what those techs do are so specialized that nobody else can do it. So you don't want them to be sick or burned out or anything like that. So taking everything else away from them to allow them to concentrate on that specialized task is very important. Pay close attention to staff needs and the care that they may need. This is it's so critically important. Everyone was suffering during the pandemic, including our staff. And so being cognizant of that, checking in with them. How are you doing? You doing okay? Making sure that they have PPE, making sure that they feel safe, in their work environment. All of that is incredibly important. And so you want to, before you're thinking about, so I said, modifying shift or coverage structure, before you do those modifications, getting input from the staff, you want to make sure that they're not burnt out. And then providing long-term planning in education, recruitment, and retention. Again, these two are so important. Without our staff, we wouldn't be able to function. And we want to make sure that they are taken care of and that they know the importance of them to us. All right, I'm going to go over some real life cases that happened at Penn. And some of these are what I consider disasters, but may not be actual disasters. All right, so case one, the Eagles won the Super Bowl. Yay! So why is this a disaster? All right, so on February 4th, 2018, the Philadelphia Eagles win the Super Bowl. Parade is scheduled for February 8th. Why does this matter to the hospital? Well, so the parade route includes numerous closures of major roads. So what do we need to consider, right? In this disaster, which isn't a disaster, right? It's a great thing the Eagles won the Super Bowl, but what do we need to consider? All right, one, this is an acute event with short notice. So I think we've got 2 days notice to come up with some alternate plans. This would be considered an access emergency. So an access emergency is an event that impacts the ability of staff, patients, or visitors to get to the hospital. So in an access emergency, the lab division administrative director or their designee is responsible for maintaining a current list of employees, including addresses and phone numbers. So they need to determine current staffing, patient schedules if this is, again, an apheresis, we look at patient schedules, resource and staffing to continue providing adequate patient care, like how much staffing do we actually need? And so the reason that this map is up here is because this right here is the Red Cross. So the pin that's all the way over to the right is the Red Cross. That is our blood provider. And then the pin all the way over to the left is the hospital of the University of Pennsylvania, 3.5 miles apart, not that far apart, right? But there's this river, this Schuylkill River, separating the two, as well as several major roads, which were closed because they were part of the parade route. So we had to consider the availability of getting blood products in an emergency. We have a courier, so we have regularly scheduled blood deliveries at Penn, but then we also have, courier runs if we are running low on platelets or a particular blood type, or if we have a patient who needs a specific type of product that the Red Cross will just send over with a courier. However, would we be able to will that courier be able to get to us in a timely fashion with all these major road closures? So these are things that we needed to be concerned about. And then let's, back to staffing. So the patient schedule, one of the things that we did was we canceled most of our outpatient appointments in apheresis, just canceled them. And that occurred not only in apheresis, but throughout HUP, because everybody was excited. They're either going to the parade or they're not coming into Philadelphia because they knew how bad traffic was going to be. So most of our outpatient appointments were canceled for that one day because, again, of this parade. And then in terms of staffing and the ability of the staff to get into the city, one of the things that we use in apheresis is we can provide overnight accommodations to staff. We have a 19-bed unit, and those beds are available to staff in emergencies. There's a staff shower that's available for them to use as well. And so it's usually utilized in like weather-related emergencies, snowstorms, and things like that. But any time where staff access would be an issue, we have the apheresis unit that we can use for them to bed down for the night. Right. So all of this information was communicated to the command center along with requests for assistance. Right. So we're talking about the hospital command center. So we had our interdepartmental emergency plan, and then that plan was communicated to the hospital leadership. All right, our second disaster, case 2. So papal visit. So Pope Francis visits Philadelphia in 2015 as part of the World Meeting of Families. Again, not a disaster. This is a good thing. But major arteries into the city were closed for multiple days. So unlike the parade route for the Super Bowl, when this was a major event that occurred over the course of a week, and the Pope visited for a few days. And when I say major arteries, I mean trains were shut down, the highway exits were closed into the city. So it was a bit of a mess. All right, so what things do you need to consider? So this is an acute event, right, with advance notice. So we at least had, I would say, 2 to 3 months notice that this was happening. So that really gave us an opportunity to come up with contingency plans. It was anticipated that normal operations in Center City, Philadelphia, including hospitals, ambulatory sites, and home care services, would be disrupted, and access for employees, patients, and visitors would be impacted. As I mentioned, commuter trains stopped prior to 30th Street Station, which is the major train station in Philadelphia, and highways blocked exits to the city. So again, this is an access emergency where staff and patients may not be able to get in. We examined our blood PAR levels and adjusted them due to the anticipated length of the closures. So instead of this being a one-day event, as I mentioned, this happened over the course of a week. The Pope's visit in particular was over the course of 2 to 3 days. And so we did make some adjustments based on that. Case 3. So CrowdStrike. I'm sure all of you are familiar with what happened most recently. Unfortunately, we were victims of this, and Epic just did not work for an entire day. So I think it came back on around 5 p.m. or 6 p.m. in the evening. All right. So Epic is down, but our LIS Cerner was still functional. However, most of the laboratory's computers could not be used, right? They all had that blue screen of death. In the blood bank, we had 4 computers that actually worked, that we could run Cerner on. So testing could be performed, but how will those results be communicated back to our ordering providers? So these are the things that needed to be considered. All right, so again, all good disaster plans start with communication. So a command center was established for the hospital that included representatives from pathology. And there was frequent communication from pathology administrative directors to laboratory managers and staff. And then we went into our downtime procedures. So luckily, our SOPs, we had access to them because we use a web-based document system for our SOPs. So all of our downtime procedures were available, our forms. We went to paper charting and apheresis. I feel a little bit old because the attending who was on service in apheresis had never done paper charting before, but I certainly had. So there was a little bit of frantic kind of, oh my gosh, what do we do? But we do have, paper charts, and we have forms and all of that for downtime. And so that was what was used. All right. In summary, disasters will happen. Preparation is key, but it's also required. All right. Remember, disasters are not necessarily the result of bad events. Okay. Your team winning the Super Bowl would not be considered a bad event. And for most people, it would be an exceedingly good event, right? But it can mean a disaster for the hospital. So effective communication is vital to any disaster protocol. Please check in with staff members. Patients are not the only ones who need care. Be flexible. Consider creative solutions. All right, this is the time to think outside the box. And then test your downtime procedures on a regular schedule. All right, this is really, really important. And then finally, learn from your experience. During the recovery phase, think about new mitigation strategies, right? And again, your recovery phase, it may not go back to what it was, and that's okay. You may learn that the way you were doing things was not necessarily the way that you needed to do things. And some of the changes that have come from the pandemic, as I said, have been sustained and permanent. So learn from those experiences. These are my references here. I'd like to thank Hub Transfusion Medicine, my division director, my administrative director, all the staff in apheresis, the blood bank, and the stem cell lab, and then also the ASPA Disaster Preparedness Committee. We've been working on a paper that describes just this, the kinds of things that are apheresis specific when it involves disasters. Again, the ASCP and the Society of Black Pathology. Here is my contact information at the bottom of the screen. Feel free to contact me directly if you have any questions. Hopefully I can answer them for you. And then I like to end with this. So our apheresis unit has won in a National Press Ganey Pinnacle of Excellence Human Experience Award 2 years in a row. So we won in 2022, and we also got it again in 2023. We are the only pathology department that I'm aware of that has won a Patient Experience Award. And I want to say this to say that the things that we do in pathology are very important, whether or not you have face-to-face patient contact, or face-to-two patient contact, whatever it is that you're doing in pathology, you are affecting the lives of patients. So thank you very much for all of your work. All right, and that's it. Again, I'm happy to answer questions, so feel free to reach out to me.